So with that, I just wanted to go in again to review the webinar and sort of what we're going to be talking about today. So according to a new report issued by Imprivata in collaboration with the Spyglass Consulting Group, 95% of hospitals believe clinical communication is inefficient during patient discharge planning. For care providers, every second counts, as you know, and being able to communicate efficiently can really make a huge difference in the successful treatment of a patient. The report does reiterate an unfortunate truth, and that is that some care settings are burdened with outdated, inefficient communications technologies and processes that not only slow down care providers, but that also jeopardize the safety of patients. So during the next hour, you're going to hear from Greg Malkery, who's author of the study, and he'll provide some insights on what he learned. And we also have Adam Davis, MD, and Liz Ames, who's an RN of Sutter Health, that are going to share their own perspectives. So now what I'd like to do is just hand this over to Greg, who's going to review some of the results of that report. Greg, I am passing controls over to you, so there you go.
Great, thank you very much. I'd like to thank Imprivata for inviting me here today to talk about how next-generation digital communications tools could be used to support high-value clinical workflows. Spyglass Consulting Group is a market strategy firm focused on the implications of mobile technologies within the healthcare industry. We've been around since 2002. My name is Greg Malkery. I'm the managing director and founder of Spyglass with some 25 years of operational experience in high technology, including large companies such as IBM, Hewlett-Packard, and Accenture, an array of smaller startups involved with enterprise software and communications. I graduated from Brown University with a master's in computer science, where I was on fellowship from North American Philips. Spyglass's current research series is entitled Healthcare Without Bounds, and with that we've published some 25 reports to date that focus on various aspects of point-of-care computing and communications, remote patient monitoring, and digital patient engagement. Spyglass customers include more than 200 leading high-technology vendors, consulting organizations, and healthcare providers who use our research to help define product strategy and direction. Spyglass conducted an end-user market study starting in December of 2016. The study was focused on analyzing market opportunities driving healthcare providers to invest in digital communications tools. It was focused on identifying specific high-value clinical workflows with communications challenges, and finally on validating how existing digital communications tools could be enhanced to improve team-based care. To accomplish this, Spyglass interviewed more than 20 healthcare informatics professionals at various size hospitals and health systems across the U.S. The report was published in May of 2017 and is now available for download from Imprivata's website. The market opportunity for secure digital communications is being driven by external market factors. Joint Commission identified the root cause of more than 65% of treatment delays and sentinel events is caused by a breakdown in communications. Joint Commissions also created a national patient safety goal for hospitals focused on improved staff communications. CMS has imposed financial penalties of upwards of 3% of total Medicare payments to hospitals who've experienced excessive 30-day readmissions for specific medical conditions. In fact, for 2017, Medicare expects to withhold upwards of $500 million from more than 2,500 hospitals. The market opportunity is also being driven by increasing numbers of nurses, physicians, and care team members who are dissatisfied with existing hospital-based communications tools. This has resulted in clinicians using their own personal mobile devices and unsecured SMS text messaging to communicate with team members. With hospitals and health systems transitioning toward patient-centered care and at-risk reimbursement models, they now have an imperative to evaluate next-generation digital tools. These tools must allow clinicians to be able to communicate with the right patient at the right time and to the right team member in order to help hospitals achieve the AAA framework by reducing cost, improving outcomes, and increasing satisfaction. One of the main objectives of this study was to identify high-value clinical workflows that have significant communications inefficiencies. According to the hospital surveyed, these clinical workflows could be divided into two distinct buckets, focused on patient discharge planning and more general patient care coordination. For clinical workflows focused on patient discharge planning, some 95% of hospitals surveyed expressed concerns about the difficulties coordinating clinical and non-clinical resources required to discharge patients in a timely and a safe manner. 85% of hospitals surveyed expressed concerns about the difficulties coordinating care with community-based resources to support patients after they leave the hospital. And 45% of hospitals surveyed expressed concerns about the difficulties collaborating with team members about medication reconciliation. This, of course, involves the identification and resolution of conflicts for medications prescribed or taken before and or during hospitalization. For clinical workflows focused on general patient care coordination, some 80% of hospitals surveyed expressed concerns about the difficulties collaborating with multidisciplinary care team members. Some 65% of hospitals surveyed expressed concerns about communications issues with transitioning patients from one medical service to another. And finally, some 50% of hospitals surveyed expressed concerns about the difficulties coordinating patient procedures and tests with ancillary departments across their facilities. Hospitals are developing clinical communication strategies. Some 78% of hospitals surveyed have developed or in the process of developing clinical communication strategies to support team-based care both within the hospital and across the care continuum. Some 75% of hospitals surveyed report that digital communications investments are a priority or an evolving priority. Hospitals are investing in digital communication solutions. 60% of hospitals surveyed have deployed a secure messaging platform. Despite low end-user adoption, 95% of hospitals surveyed are planning new or incremental investments over the next 12 to 18 months. The second objective of the study was to identify how digital communications tools could be enhanced to improve a clinician's ability to connect, communicate, and collaborate in order to enhance productivity and efficiency, improve care quality and outcomes, and increase clinician and patient satisfaction. Let's start off by talking about enhanced capabilities to improve a clinician's ability to connect with care team members. All hospitals surveyed specified care team identification as an important capability. This allows clinicians to quickly connect to care team members by automatically leveraging current and accurate on-call schedules, care team assignments, and enterprise-wide directories. 95% of hospitals surveyed identified availability, presence, and escalation management as important to support collaborative team-based care. Availability management is targeted at clinicians who have 7 by 24-hour patient care responsibilities. It allows them to manually or automatically publish their status, which could include that they're busy, they're at lunch, they're in a consult, or even on vacation. Presence awareness is targeted at shift-based workers. It allows them to set their presence based on predefined work schedules. And escalation management allows alerts, alarms, and notifications to be escalated to a supervisor if a notification is not responded to within a defined period. And finally, 90% of hospitals surveyed identified native cross-platform support as critical. It allows care team members to use a wide range of different endpoint devices, including hospital and personally owned mobile devices, and desktop computers and laptops. All right, let's talk about enhanced capabilities to improve a clinician's ability to communicate with team members. 80% of hospitals surveyed identified unified communications as critical. This allows clinicians to leverage different communication modalities, including voice, video, and text messaging across the care team. And finally, let's talk about enhanced capabilities to support collaboration with care team members. 95% of hospitals surveyed identified click-to-communicate functionality as an imperative. This allows a messaging app to be launched from within various clinical applications, including the EHR, lab systems, pharmacy systems, or even the physician portal. Clinicians can select their communications type, which will automatically aggregate patient demographics and clinical content based on hospital policies and procedures. 65% of hospitals surveyed identified communications thread management as important. This allows clinicians to send and receive care messages that are organized by patient or by topic. They can also selectively store clinically significant communications within the EHR, which is something that's not done today. And finally, some 60% of hospitals surveyed identified structured communications as critical. This allows clinicians to leverage structured templates, forms, and lists to communicate complex clinical data that's both actionable and consistent. So in conclusion here, based on the report that we've just written, with the passage of the Affordable Care Act and the transition toward value-based purchasing, hospital IT has an imperative to evaluate next-generation digital tools to help achieve the AAA. Spyglass discovered in the scope of the study that some 95% of hospitals surveyed are planning new or incremental investments in these tools over the next 12 to 18 months. Many of them believe that enhanced digital tools, when combined with adaptive clinical workflows, could address many of the inherent communications inefficiencies that we discussed during my talk today. Hospitals surveyed also identified specific digital tool enhancements to improve a clinician's ability to connect, communicate, and collaborate. Just to reiterate here, some 90% of the hospital surveyed reported that care team identification, care team member availability, and cross-platform support could enhance and expand care team collaboration both within the hospital and across the care continuum. 90% of hospitals also believe that unified communications could provide team members with increased flexibility and choice. And 60% of hospitals surveyed felt that click-to-communicate, communications thread management, and structured communications could help support data-driven closed-loop communications. That's all I have for you as a review of our readout of the report we had, but I'd now like to transition to the Sutter folks, Adam and Liz, who will then tell us about their experiences at Sutter.
Thank you, Greg, for that presentation and giving us a great overview of the industry and the industry's needs. I am Adam Davis. I'm a pediatric hospitalist, MD, who is also board certified in informatics. I wasn't going to mention this, but interestingly, I also went to Brown University and graduated years ago. And I've been at Sutter Health for nearly 9 years in their informatics structure for 5 years. Liz, would you like to introduce yourself?
Certainly. My name is Liz Ames. I am a registered nurse, clinical informatics assistant analyst with Sutter Health, whose main focus recently has been on our interoperability tools and efforts.
Thank you, Liz. So I wanted to talk a little bit about what I've learned as a practicing informaticist and a practicing doctor about the needs of our providers and our care teams' communication at Sutter. Briefly, Sutter is a...
Adam,
yeah.
I'm sorry, this is Mary. Are you able to control the slides? I did pass controls. Did you see that?
I am, I think.
Okay.
Did you?
Okay.
I just advanced it, and it seemed to advance. So Sutter is a health network in mostly Northern California, but it also leaks into Southern California and Southern Oregon. It's a large healthcare network. We have 24 acute care hospitals. We have over 5,000 physicians aligned. We have also 5,000 additional employees, and you can see on the slide that we have $11 billion in revenues and various different care models. So we both have home health and hospice services. We have inpatient, we have outpatient surgery and outpatient specialty care centers. We have medical research with medical education training with residencies, and we have walk-in care clinics. So we really provide the whole spectrum of care for patients in Northern California and for millions of patients in Northern California. So when we think about what we need to communicate, first of all, we think about who. And as Greg mentioned, ideally you want to be able to identify the care team if you're going to be communicating the messaging. And that's really been a struggle. There's, one of the things we talked about was putting in your on and off hours and escalation tools. And I think that's really key, but even further go down the line with not having the end user need to do that, having it be integrated with someplace else, was the scheduling and the patient matching was already there. So physicians are often scheduled through scheduling software. Those sites, perhaps an ideal tool would be able to pull in that information to know who is on call at a given time, to know, and nurses are often scheduled similarly and have patient assignments. So that sort of matching, automatic matching would be something that would be appreciated. And that's sort of the idea of reaching the care team. Not just do you need to be able to reach the right person, but if that right person doesn't respond, you need an appropriate escalation point and an appropriate escalation to the appropriate person. But the other question about who that we've struggled with is breaking both internal and external silos. So I've talked about the docs, mentioned the nurses, but we also have case managers. We have all sorts of therapists that all work within the hospital, and be able to identify not just the RNs and MDs on the care team, but the case manager on the care team, the social worker on the care team, the nutritionist on the care team. So really there can be a robust way to contact whoever it is that you have a question for about that patient is important. Those are the internal silos. Externally, there are even greater silos. And so we struggle with that with, perhaps their cardiologist is not a Sutter cardiologist. Perhaps they are at UCSF or Stanford in our area. And so how do you communicate across different, and that's where I put this word direct communication, which is a technology some of you may have heard of, which is identifying a way to communicate with, in a secure way, mostly with physicians at this point, but across different health systems. And that's important. And additionally, outside SNFs, outside post-discharge care centers, outside outside services that we would not regularly have communication within the hospital is an important thing that we communicate with to improve the care of our patient. I think this is something that's important too, and so I think about asynchronous versus synchronous communication, and I'm sure you guys are familiar with that terminology. Most of the communication we do in the hospital is designed to be synchronous, like the texting or certainly the phone calls, where we're trying to get real-time information back and forth, but that's not always necessary. Sometimes asynchronous communication, where it sends the appropriate communication to the person that they can then review at a later time, is sufficient. And really that's workflow dependent. And having the appropriate match of synchronicity to the appropriate workflow is a really important match to understand. Avoiding alert fatigue, if you're identified on the care team, for example, in the previous slide, I spoke about how a care team is not just the doc and the nurse, but it's also the therapist and the case manager and the nutritionist and the perhaps the pharmacist, et cetera, et cetera. You don't want everybody on that care team getting every message that may not apply to them. So how do you figure out a way to have these groups be very dynamic, to have them be appropriate, to have the appropriate message get to the appropriate person? how. So certainly, as Greg mentioned, we are all used to being able to access our information on multiple devices. We certainly learned that through our Gmail account, through our Facebook, and we expect the same sort of thing when we're at work. So certainly, we expect to be able to do that through our phone, through pages still can be useful, and especially with how phone coverage can work in certain hospitals or certain clinics. We expect that to be on a desktop device, and we want it to be, but a really important idea here is also that we only see the message once. So I'm sure other technologies, we've all experienced where we sort of read something one place, but then we go look at it on the desktop and we have to sort of read the same information again, and that feels redundant and time wasteful. We also want it to be integrated with our clinical workflows. If it's not enough to be on the proper device, it also has to be appropriately in the place that we're already in that device. And then we want to be able to get into that area quickly. And that's some of the burden that we have is that the non-HIPAA compliant messaging that often goes on in hospitals through standard carriers, SMS messaging is so easily accessible. And the barriers to getting our providers to use it is that the current, we want it to be as accessible and easy to use as the current state of what they're doing. So, and then lastly, I think about the why. And so, like, why should they use this device? And we sort of talked about, we can, from an administrative point of view, we want them to use it because it complies with the patient privacy laws. But we also want them to use it, but we want to have more carrots for them and less sticks. So we want it to be ease of use and to seamless integration with clinical data, which is something that Greg mentioned in terms of having some of the patient information travel with the message appropriately. But if we could add in certain tools about how it interacted with the EHR in terms of if they could place orders directly after a message or other actions to create letters or scheduling events, that may increase the value of the messaging platform enough to increase take-up. Because truly, for us, the largest, at Sutter at least, the largest impediment to using this is the take-up. So I sort of view the ideal messaging platform as a little bit of a, the search for the Holy Grail. It is worth the search because we learn so much as we do it. But, to get the who, the when, the how, and the why correct for every use case is challenging. So the way that we approach it, at Sutter at least, is we think about launching these things with specific use cases and then hoping for leakage into the greater community. Because as is relatively obvious, the uptake of the platform, it becomes more valuable as more providers and more clinicians and more team members are using it. When there's a few people using it, it has less value. So getting that getting early adopters can sometimes be a roadblock. So the Sutter experiences, we've actually gone through now 2 secure messaging platforms. We still have poor uptake. We certainly had poor uptake in the first, and we had relatively poor uptake in the second. And they're not providing sort of the global communication platform that we hope we one day will have. Part of the challenge is the heterogeneity of our work and the multitude of customers and use cases. So we have had pockets of success, but the overcoming the barriers of leakage through non-approved channels and MDs having multiple business relationships with, perhaps they work at 3 or 4 health systems and they may not want to learn 3 or 4 different communication platforms. Nurses, so we have mostly unionized nurses, and they're bringing their own devices is a negotiation process with the union. So far, we haven't been able to do that. And so how are they using a communication platform that's designed mostly for a mobile device or is more easily used in a mobile device And if they're restricted only to desktop, how valuable is that to them? And then lastly, the truth is we still have a multitude of communication pathways. We don't want to shut down ones that are already successful. So as we roll out more, we're sort of adding other layers. We hope that if we get to a great communication platform, we would be able to, people would self-select to use that rather than some of the other pathways that we have. But at the same time, we can't break any of the workflows to do that. So I just wanted to list out a couple of desired functionalities that are sort of that either weren't mentioned in the previous talk. I talked a little bit about, or weren't mentioned in sort of in Greg's talk. And one, we talked a little bit about messaging across systems, but I really want to stress that the ability to manage multiple accounts across health systems is very important to our users because of how much, how both providers and patients move across the systems. We've also noticed that whether these messages are part of the permanent medical record is very important to providers and very controversial. And in some ways, maybe the answer isn't one or the other. Maybe it's that it could be either. And here, you may have some care planning that goes on that really doesn't need to be part of the record, but there may be some important text messages that show some decisions that somebody on the care team has made that they want to be part of the record because they want to document that both for legal and medical reasons and communication reasons. And we do feel that we haven't seen a platform yet that really allows you to do both. It's either a purge or it's a file, and maybe there's a way to have something in between. We also have struggled with something that's very particular to, I believe, the iPhone. I don't know if the Android's the same way. But if the phone is muted, it seems impossible for the apps to overcome that mute. So often, providers don't want their phone to be on ring when they're seeing patients because that means that all the calls and texts they get from family and friends would be coming through while they're trying to be focused on a patient. But at the same time, if we're using this also to replace pagers, we need to have a system that's reliably going to notify that provider that differentiates itself from other alerts on their phone. And since the phone doesn't differentiate the different apps, that can be a real challenge. I talked about the ability to communicate across more than one health system, but also the ability to be in more than one health system. So from the provider's point of view. So, and then lastly, communication analytics. So ideally, we would also be able to use the communication to figure out the pathways of communication that are happening successfully and unsuccessfully within our organization so that we could not only use the tool to directly improve patient care, but use analysis of the tool to improve our workflows over time. That sort of covers, my experience at Sutter and doing rollouts with the secure communication tools. I do think that it's much. I found it being involved in. I found it much more fascinating and challenging than it would be at face value. And I think that there's still a number of challenges to any organization that's trying to implement a single solution. But it's something that we should all work for because currently there are many holes in our ability to communicate with our care providers that cause the inefficiencies that Greg spoke of. Thank you.
Great. Thanks so much, Adam, and thank you, Greg. I think it's really important for us to get a wide array of point of views and better understand what's going on in the industry because secure communications is something that we continuously see as important to healthcare providers, important to the workflows that different clinicians and nurses are using on a day-to-day basis. So it's great to understand how different organizations throughout the industry are dealing with this and with different products as well. I know that, Adam, you guys at Sutter are not using Imprivata Cortex, so it's important to get, you know, a full view of what different solutions are offering and where the need for stronger communication across the board is. So thank you guys both for that great point of view. We're going to get into questions in just a second about what we've talked about today. But just a few quick housekeeping items. Just a reminder that a recording will go out to anybody who registered. And if you have any questions after the occasion, you can shoot an email to information@imprivata.com on the screen right there. And with that, we can get into questions. As a reminder, please feel free, anybody on the line, to enter any questions you have in the Q&A panel on the bottom right hand of your screen. So we do have one question that came in, and I'll pose this to you or Adam, Liz. At Sutter, how do you guys deal with clinicians who are weary of change and who aren't quite willing to implement a new solution like this?
Well, we could spend, you know, the next couple of weeks talking about change management. It's a challenge, and it depends on a lot of things. So, you know, there are many roles at Sutter, and so when we're talking about clinicians, even the clinician roles, you know, RNs are direct employees of the hospital, and so they're a little bit more in an employee-employer relationship, whereas the MDs are generally not quite in that relationship. So we try to work with people to show them the advantages of the change they'll be getting. They're not always happy. Obviously, the largest change we've implemented in the last decade was the AHR itself. That was a demonstrably big change, and it affected workflows in a huge way. It caused a lot of consternation. We also know that our providers would not go back to not having the EHR given the choice, but they are also not happy with the EHR. And so we see that a lot with change. We try to do a lot of education. We try to anticipate concerns. We try to pilot things if we can, depending on the build and the product and whether it works in a pilotable form. And we try to listen to our customer as much as we can. And then, you know, some of it is getting some high-powered allies who can sort of show the way. And so if that's a resistor, we may meet one-on-one with them to talk about a project, to try to get them on board earlier. If it's a champion, we may use them to sort of help champion it across the system. Liz, do you have anything to add to that?
Sure. The only thing I would also add to it is just as Adam had mentioned, the complexity of having users that are not necessarily even, they're affiliated with your organization, but they're not employed by them, and they might be using systems and other types of communication systems or other EHRs, and so trying to limit the amount of input they get as far as what's changing, where is it changing, how does it affect me, and so just trying to coordinate those challenges of changes over and over again in different systems, and it is quite interesting. But again, communication is the key, and getting champions, particularly with physicians, is huge. If you're able to get champions in there to say, I use it and this is the advantage, and I know it's not perfect yet, and again, that's really key. Don't offer something that's not perfect as being that way. If there are quirks, if there are challenges, be transparent about that, and then say this is what we're doing to address those.
And you know, the other word I would use is empathy. So, I mean, I think it's hard. There's every technology and then every tweak of the technology we make is a real change process. And not everybody is as comfortable with technology as probably the people on this webinar. And so I think being empathetic about that so that when you communicate, you're communicating from their point of view. You're communicating not too much, but not too little. Just really thinking about how the experience is as an end user and acknowledging that it's challenging having, you know, going into healthcare and having those skills and being on a rapid technology voyage now.
Great, thank you. Thank you both. That was really insightful, and I think it's important information for healthcare organizations looking to employ a secure communication solution to understand, so I appreciate that. And with that, it looks like that's the last of the questions that have come in, so I think we can go ahead and wrap up. Again, anybody, if you have any questions that come up later, please feel free to shoot an email to information@imprivata.com, and someone will be able to help you out with that. And with that, this concludes the webinar. Thank you, everyone, and have a great day.